Buen Día Internacional de las Personas
Happy
Cuidadoras.
International Caregivers Day.
International Caregivers Day. El webinar de hoy
Today's webinar will be conducted in Spanish
al inglés.
with simultaneous interpretation into English.
In Spanish. If you want to listen to it in English, click on the interpretation icon located in the toolbar and select the English option. Bienvenidos al webinar
Welcome to today's webinar, Caregivers Day, Challenges Faced by Caregivers in Latin America and the Caribbean, organized by the Inter-American Development Bank. This webinar is part of the Panorama of Aging and Long-Term Care series, which we launched in February 2020. In this series, we share experiences on the design, implementation, and evaluation of long-term care systems. My name is Marco Stampini, and I'm part of the Social Protection and Health team here at the Inter-American Development Bank. Why are we here? The aging of the population in Latin America and the Caribbean and changes to family structures and dynamics have placed the care of individuals at the top of social policy agendas. Nowadays, informal care is mainly provided by women, resulting in physical and mental wear and tear and fewer job opportunities. Development of this sector is part of the 2025 vision, Reinvesting in the Americas, which is the IDB's roadmap for helping our region make the most of opportunities for recovery, reinvestment, and long-term development from the perspective of inclusion. Consistent with this vision, the care economy has the potential to create millions of quality jobs and to contribute to gender equality. We are honored today to be joined by Claudia Miranda Castillo, who will look at international evidence and pending challenges with respect to the situation of informal caregiving in Latin America and the Caribbean, with a particular focus on the mental health of informal caregivers. Claudia is a psychologist with a master's in clinical psychology and a PhD in aging and mental health. She is currently an associate professor at the School of Nursing at Andrés Bello University in Santiago, Chile. She also serves as director of the Millennium Institute for Research on Caregiving. You can find more details about her professional career in the webinar section of the IDB's Panorama on Aging and Long-Term Care site and in the Zoom chat. Before handing the floor over to Claudia, let me explain some logistics. We will have a 40-minute presentation followed by a Q&A session. We invite you to ask your questions in either English or Spanish, either is fine, using the Zoom Q&A button at the bottom of your screen. Please bear in mind that your microphones and cameras will be disabled. Thank you to those of us who follow us on our Panorama website, and for those who are not already doing so, we invite you to follow us. Please go ahead, Claudia. Thank you very much, Marco, for that introduction. I would also like to thank the Inter-American Development Bank for the invitation to give this webinar. I am very pleased to be able to talk about caregiving for older adults in Latin America and the Caribbean. Just as a point of departure, I would like to provide some background information that's important to bear in mind when we're talking about caregiving in both Latin America and the Caribbean. Above all, when we're talking about the care of older adults. In our countries in Latin America and the Caribbean, they are predicting an increase in the number of persons age 65 or older from 9% to 19% between 2019 and 2050. Another piece of background information is that the number of individuals 80 years or older will sextuple between 2019 and 2100. Another piece of information that's important to bear in mind and that we're already aware of is that as people age, their ability to meet some of their own basic needs diminishes. And in these elderly adults, there's a greater number of women who lose their functional capacity compared to men. Bearing all of this background information in mind, we are led to the question, what is happening with caregiving for these older adults and these profiles, looking at some of the trends that are being forecast? We know that in Latin America and in the Caribbean, what is most frequent is informal care. This has to do with a number of different factors that often relates to Latin American culture. The focus on the family, having these very tight family ties, and an approach to addressing any challenges or issues from a family perspective. There's also very low rate of coverage in terms of Social Security and high poverty rates in the countries of this region. This means that no support system necessarily exists for caregiving. In addition, also due to this focus on the family and our culture, that most individuals in our region prefer to age at home around their families where they are surrounded by close loved ones. Taking all of these factors into account, we see how informal care is often the only option available to handle a situation like this. In other words, when we have an older family member who needs long-term care, if there are no comprehensive support systems available, we're often left with no other choice than providing informal care. What is more, this context is very culturally based. In other words, we believe we owe something and want to return the favor to those who took care of us when we were young children. And so that's what leads to informal care. According to the literature, an informal caregiver is someone who is a family member, a friend, or somebody else in a person's close circle of contacts who is not paid for their work and often is not trained or educated in caregiving. The literature distinguishes between informal care and informal caregivers. They talk about paid work as a necessary condition for considering someone a formal caregiver. In those cases, they may be professional caregivers. They may have received some training in how to provide care. We also find caregivers who may be paid with may be paid for their caregiving work, but these may be very precarious situations, precarious contracts, and in many cases, they have not received specialized training in how to provide care. In this context, I believe it's very important when we're talking about care to take a gender approach to our examination. In our region, informal care, generally speaking, is done in the vast majority of the cases by a woman. Women are the ones who take on the burden of care. This is due to the patriarchal culture that predominates in the region, where caregiving is considered a natural ability of women. Therefore, women are under the assumption that they are the ones who need to take on caregiving duties when someone in their family requires care. We've seen this for a long time now in terms of the way work is divided by sex. This is something that continues to be true. Men are considered to be the providers. They are the ones who are expected to go out and work in the labor market. Women are more associated with domestic work and therefore caregiving. We know, of course, that women are the ones out there working more, and there are more men taking on household chores and responsibilities. We're seeing that change over time, but women are carrying the bulk of the burden of household work that is not paid. There are attempts to redistribute the tasks both inside and outside the house, but that's not enough because women continue to bear both the domestic work responsibilities and caregiving responsibilities, comparatively speaking. Looking at all of this information and existing literature on the topic, the conclusion is, and this is something we already know, that women are far more likely to become the main caregivers of a person requiring long-term care or in raising children, devoting far more time to caring for their family members where necessary, much more time than men. This has to do with supporting them in their daily activities, feeding them, domestic chores, and in having to invest much more time than men do in these activities and tasks has a significant impact on women's physical and mental health. When we're talking about informal caregiving, where the individuals providing the care have not received any training that will help them address all of the different facets of caregiving, it happens in different environments. And I was talking about that a bit earlier. For example, when it comes to healthcare, we've seen the intensity of the effects of informal caregiving, and it differs based on gender. Generally speaking, we know that people who devote many hours to providing care are the ones who feel and experience a more adverse impact on their own health because of how intensive caregiving can be. We know that the impact is more serious in women. And why is that? It's because women have different ways of taking on and carrying out care. Women who take on the burden of care are much less likely to seek out other sources of support. And when they do resort to asking for help from other members of the family, they tend to do so much later than a man would in the same situation. This means that women spend much more time providing care on their own. They also tend to take on caregiving roles that are much more difficult. For example, bathing or cleaning the individual, dressing them, among others. And this has an impact on both the physical and mental health of women. The activities men take on tend to be more administrative in nature. For example, taking the older adult to a doctor's appointment or providing money to pay for some care. The tasks they engage in tend to be much less physical than the ones women take on. The impact of informal care is also seen at an economic level. Women caregivers are much less likely than men caregivers to be out in the labor market. They work far fewer hours of paid work, and then they have to adjust their schedules, their work schedules, to take on their informal caregiving responsibilities. So it's a double-edged sword. You've got women who basically have two different jobs. So they have the caregiving job, and those who do not find themselves in much more precarious straits in terms of seeking out any support they might need to provide care. Some leave the labor market once and for all, and this can have major consequences for their mental health. What are we seeing in terms of economics? We see that women who are lower income are more likely to serve as caregivers, and there's a vicious circle. This means that their financial burdens are greater because they're working reduced hours. Or they've had to retire earlier. And going back to this vicious cycle, we've seen women in a more precarious situation. The situation is perpetuated. They're not able to escape poverty or their low income status. A researcher named Angeline Justo Ampuerdo notes that there is this negative impact of informal care. And what's important is that caregiving has to move from the private sphere to the public sphere. We have to distance ourselves from this matter that this is invisible or it's something that only women should do. The idea is to shed light on the situation at the public policy level. States must take on the role of creating systems to support caregiving. In the long term, this would lead to lower needs for government spending. For example, informal caregivers tend to use services even more because their own health is suffering, and that is a financial burden for states. Now, I would like to speak about the informal care for dependent adults. If we take a look at the situation in Latin America and we look at evidence about informal care for older adults who require long-term care in Latin America, there's not much literature if we compare it to other more developed regions, for example, European countries or the more Anglo regions of the world. Defining and measuring long-term care needs also varies. There are differences in methodologies. They're quite different when looking at how to measure the situation of long-term care dependency in the situation. This makes it difficult to compare what's happening in one country versus another. Nevertheless, there are common patterns that we will take a look at. Here we can look at Colombia. Research regarding informal care has focused on care for individuals with chronic diseases rather than dependency in older adults. When looking at informal care for persons with chronic diseases, and which is not unusual, we're looking at 72% of those caregivers are women. The average age is 43 years. 75% come from lower socioeconomic strata. 46% have not completed high school. And 50% are working without pay. They spend an average of 8 years doing so. So the older the person, the higher the level of overburdening of tasks. So we look at the socioeconomic status of the caregivers, the level of schooling, their ages, and the negative impacts. We are going to see that the situation is quite similar in the different countries based on studies and surveys conducted in those countries. In Brazil, this is a study based on a very large survey conducted in the country. It was done about dependent older adults. Looking at the figures, 84.5% of informal caregivers of older adults requiring long-term care are women. 52.4% are between 40 and 59 years of age. 46.4 are daughters of the older adult. 48.8% have been caring for the individual between 2 and 5 years. An important piece of data having to do with health is 60.7 report having some sort of disease. 75% report emotional and social problems. This shows us the impact that caregiving can have, or at least the ties between caregiving and the health of the individual caregivers. In Chile, where I'm from, we were able to obtain data from the socioeconomic survey. Indirectly, we were able to discern who were the informal caregivers for older adults. It's not that this was a direct question asked, but the information could be gleaned based on some other general questions about persons older than 60 years of age. some of the tasks they do. This is a national survey. We saw that 66.8% of caregivers were women. This is obviously a pattern we've seen in all of the countries. Their average age was 56.5 years of age, 44.5 are daughters or sons, and 33.6% were the spouses of the person for whom they were caring. 43.4% had only a elementary school education or less. Therefore, we are talking about people with quite low levels of schooling. Just 15.4% had higher education. This is tied to the piece of data I just gave you. And just 36.5% stated that they had other jobs. In other words, these were the only ones who had an occupation outside of their caregiving duties. In Argentina, and this also had to do with care for older adults in a situation of dependency, 71.4% of the caregivers were women, 45.6 of them were older than 60, 43.7% of these caregivers had not quite completed high school or had less schooling. So we are seeing the same pattern of schooling levels in these caregivers. The findings of the study noted that women from lower socioeconomic strata who did not complete high school were the ones most likely to take on caregiving duties for older adults requiring long-term care. What can we conclude if we sum up the findings of these studies? 80% or more of care is informal. Some other elements in common is that most of these caregivers are women. Average age is between 40 and 60 years of age, with low or medium levels of schooling. They tend to be low income, and most state that their physical and mental health is not the best. If we look at all of these elements in the different countries, it leads us to believe, or it leads us to ask what governments can do, or individuals or families can do in order to improve support networks and to change some of the structural determining factors involved. It's about policy changes that go beyond the individual, for example, income and schooling levels.
I also wanted to include in this presentation aspects that have to do with contingencies, what has happened with the informal, or rather dementia, not contingency, in what's happened with the informal care of persons with dementia in Latin America during the COVID-19 pandemic. And there's a multinational study that was carried out in Brazil, Argentina, and Chile, in which the objective was to look into the impact of social isolation due to the COVID-19 pandemic on persons with dementia and their family member caregivers. There was access to 321 family member caregivers of persons with dementia, And this dementia could have any etiology and different levels of dependency. There was a phone survey that was carried out in order to access these persons who were, in effect, were in control of the services, or or I should say, had access to healthcare services. Nonetheless, at that point in the pandemic, they were not necessarily going to face-to-face checkups, and a semi-structured questionnaire was applied to them on perceptions of changes in persons with dementia and their caregivers. Now, some brief results and conclusions. We find that the average age of those who participated was 59 years. 79% of the persons who were caregivers, informal caregivers of persons with dementia, were women. And they had, on average, 12 years of education, which suggests to us that this sample has a educational bias in which the caregivers who participated in this phone survey had a higher level of schooling than one generally sees in persons who provide care to older persons. Now, what was the main result when observing, or what did caregivers report in terms of what was happening during the pandemic compared to what was happening before the pandemic? The informal caregivers of persons with dementia reported a deterioration in their physical and mental health during the pandemic, and those who were most impacted were persons who cared for persons with moderate to severe dementia. And what they were saying when it comes down to it is that on having to effectuate many more caregiving tasks with the heavy physical burden and so forth, not having access to or being concerned or anxious about going to medical appointments and so forth. One was not able to go out because of restrictive measures that were in place at the time. This also had a negative impact on their health, that they had their job became much more complex. Some of them also had caregivers or family members who helped with the caregiving tasks. But because of the social distancing restrictions of the pandemic at that time, they were not getting that help. And this also takes its toll on physical and mental health. The importance of these reports is, well, the need to continue monitoring the needs and social and physical and mental health of these caregivers, their needs in the post-pandemic period, and what happened particularly with those who or attending particularly to those who were caring for persons with moderate to severe dementia. The idea is to take stock of the situation and monitor those needs because they indeed may have changed as a result of the pandemic. Now, stepping outside of the context of COVID for a moment, I would also like in this presentation to show you some policies that are being implemented having to do with caregiving of persons with who need long-term care in Latin America. Now, there are some countries which, in one way or another, have designed and are gradually implementing some caregiving systems. For example, in Uruguay, it is called the Integrated National System of Care. Who is served by this system? Well, it is served by people who have a situation of dependence, who need long-term care, or who have suffering a disability of any age. Eligibility for entering this program or the system has to do with the level of dependency of the person, caregiving, and age. Now, or caregiving needs and age. The services specifically provided to older persons are personal home assistance. This is home-based caregiving, telecare for persons who are 70 years or older who are moderately or slightly dependent, and also daytime centers that are accessible free of charge for a person 65 years or older. Now, what is the coverage? That's also important. In the case of Uruguay, only 5.9% of the population 70 years or older who require long-term care are receiving some type of service from this system. Now, among those who sought such services, the coverage rate is 67%. That is to say, persons who seek out this help can get it, even though nationwide coverage is still low. Now, how can one guarantee the quality of these services? Well, required training courses are given for caregivers. Minimum standards are established, also for authorizing long-term residential facilities, basic standards having to do with infrastructure, services, human resources, how many personnel, the care that is provided, and so on. And this is done at the national level in Uruguay. Next. Now, what's the situation in Argentina? In Argentina, there is what is known as the integral or comprehensive medical care program. This is an integrated a model of integrated supply of social and health services for older persons. Now, who gains access to these services? People who are retired, pensioners, and veterans of the Malvinas War and their family members. The beneficiaries of these services are prioritized depending on how dependent they are, their age, their medical condition, and their socioeconomic status. Now, what are the services that are provided for older persons? Well, clubs and day centers, geriatric institutionalization or hospitalization, and subsidies, home care and economic, home care and economic. So this is a basket of services that is provided to help care for older persons. Next. At this time, 88% of persons over 60 years of age in Argentina are affiliated with this system. But recall, these are these are distributed depending on the extent of dependency, age, and so forth. And in the context of the program for home caregivers through provincial governments, local governments, universities, civil society organizations, free training courses and updating courses are provided for caregivers. Also, quality is guaranteed insofar as the day centers need to have a commercial accreditation. Likewise, the long-term residential facilities, they also need to have a health accreditation, and they also must comply with the requirements demanded by the Superintendency of Health Services. Now, in Chile, there is the National System of Support and Care, and this is under the Ministry of Social Development, and it provides care services to persons who are dependent and also coordinates the supply of these services in the different communities. These services offered based on age, extent of dependency, and income level. Now, among the services we find, one also finds home caregiving, day centers, long-term residential facilities, professional services with different kinds of therapy, and also transfer financial resources to the local governments who are participating in this support and care system. Well, what more can I tell you about it? The system in Chile, well, it operates in 20 out of the country's 346 localities, so coverage is still very low, and the minimum requirements and in terms of managerial capacity and offer services are determined at the local government level. Needs are determined and the assistance is provided. Then there's also inspection of long-term care residential facilities. This is what we have in Chile. I'm going to move very quickly through the rest. Yes, just a reminder, if you could conclude in the next 5 minutes to leave time for Q&A. Well, final thoughts? Mindful of all of the evidence that I've shared with you, informal caregiving is, we know, a complex phenomenon that includes several actors. You have the person who is dependent, the person who's providing care, the community, and the state. The care must be conceived of as a right that should be guaranteed by the state. Let's also keep in mind that it's important that uh, caregiving is considered not only to be the assistance itself, but also promoting the autonomy of the individual. That's also important. And this has to do with the fact that the caregiving systems exist as an integral uh, public policy on an intersectoral basis. And this includes measures not only to provide assistance to older persons, but also benefits so that women caregivers can also have a job, a paid job. There's a registry keeping track of caregivers and so on. The challenge in those countries in which there is already some care system is that there might be a gradual increase in coverage, and these systems should also be flexible enough to adapt to uh, needs as they evolve in relation to caregiving work. And in terms of research, it's necessary to generate scientific evidence of quality so as to feed into these state policies. And so, and I'll, here in Chile, the Millennium Institute for Caregiving Research was established, and I am the director. I'm also a researcher. The objective of the Millennium Institute for Caregiving Research, MiCare, or MiCare, is to generate scientific knowledge on formal and informal caregiving in respect of two groups, persons who need long-term care and persons who have intellectual disabilities and developmental disabilities. Next, we have 4 lines of research which have to do with socio-cultural aspects of caregiving, interventions for formal and informal caregiving in older persons who are dependent, care versus accompaniment in persons with intellectual and developmental disabilities, and a line of research which has to do with technology and caregiving. So this is my email address, and we would invite all individuals and organizations, be it civil society, research or institutions, etc., to contact us. The center has been established precisely to pool efforts around caregiving, and I'm most grateful for the opportunity to share this presentation with you today. Thank you very much. Thank you very much, Claudia, for this presentation, and I'd like to thank all the participants for joining and for the questions that you have put into the Q&A. We're now ready for the next part of the webinar, and the first question is from Patricia from Chile, and Patricia says the following. Claudia, you mentioned at the beginning of your presentation that many formal caregivers do this task without adequate training for caregiving work. Is there any experience you could mention by way of example in terms of how and in what training is provided to informal caregivers? And also, she notes excellent presentation. Thank you, Patricia, for the question. Yes, I can tell you, indeed, the National Caregiving Program that Chile now has wide coverage, but there too, tools are offered to caregivers in different respects. One has to do with particular caregiving tasks, physical tasks, how you care for a person who might be very highly dependent, how you change diapers, how you deal with feeding or food. All of this has to do with care activities of that sort. There's also training, or well, not training, but support for emotional or mental health of caregivers through support groups. Chile Cuida also had this option, and it's part of the national care system. Uh, You can talk and discuss your experience with other peers who are doing the same work, guided, of course, by a facilitator who is trained to that end. There are also some interventions which are particular to certain conditions, such as, say, dementia, where there's training for in managing the symptoms in particular. There's also some psychological education regarding this illness. A- And so in both literature and in practice, there are interventions. The thing is, we don't have a policy that integrates all these interventions. And to that end, the national caregiving system is being further developed. Work is being done so that it can gradually take on a larger number of communities and answering to the needs for caregivers nationwide. Claudia, follow up to this question. What are the competencies that are developed or the skills that are developed in these trainings? What are the main ones? The main competencies, well, I think it also depends on the way in which the training is provided. Many of these trainings, when done online, well, there are websites, both of the digital hospital and in uh, Senama, which seeks to foster uh, competencies. Well, it's more education. I'm not sure how to call it, what to call it formally, but there is a question of educating about what is caregiving and what is self-care as well, which is extremely important, in addition to the competencies that are particular to engaging in caregiving activities. So those are the fundamental pillars that I have seen in country level or system, caregiving system level interventions. Those are the three pillars. Thank you. Now, a question from Beatrice. The data show that care is understood as a natural condition of women. How could males be sensitized so that caregiving not be seen as something falling exclusively on the shoulders of women? And also, are there examples of successful policies and countries where this has been attained? That's a very complex question. I don't know if I have the answer. I think that in effect, the feminization of care has to do with a cultural factor which is deeply rooted, and all cultural changes take time for change to come about. It's a long term. It's not something we're going to change in the very short term. Now, what measures can be taken? I think that there need to be macro level measures in terms of the state, in terms of public policy, as well as more micro level measures at the level of the household, for example. And this begins with child rearing, not just when one is caring for older persons who are dependent, for example. More flexible working hours should be promoted, and also jobs should be created so that people can be remunerated, and it should be possible to carry them out in a more flexible manner. Well, we've seen that telework is possible with a, uh, and this could help caregivers emerge from the precarious economic situation and also distribute tasks in the household, which is the other issue. When it comes down to it, how do we educate couples or males, boys from a young age, so as to model distribution of tasks in the household, including caregiving, be it domestic, caring for the grandparents? Well, it has to do with both males and females. So those changes need to take place at the household level, at the micro level, but there also need to be changes at the country level. And that is complex. And it's going to take time. we can give visibility to it. The first thing is to give visibility, and that's being done, but it doesn't suffice to give visibility to it. There needs to be a will and a political will and a will on the part of the authorities in order to bring about those changes. And that also involves giving greater visibility to the problem, or beyond giving it visibility, generating knowledge, generating evidence. And that's what we're also trying to do at the Institute. Thank you, Claudia. A question from Brenda from Mexico. Could you tell us something about the experience of paying family caregivers? Uh, where is the money come from which part of the budget, and how is caregiving monitored? I'm going to talk about the particular case here because I'm not as familiar with the level of detail of the others. Now, here in Chile, the allowance or subsidy that is given to informal caregivers comes from the taxes that we all pay. And that stipend is very insufficient when we look at it as a sum of money itself. It's extremely insufficient. It's really practically nothing. Therefore, what is being attempted with the caregiving system, which covers different types of subsidies, it's not necessarily a cash transfer that is given to persons who are registered nationally as being disabled or dependent. These are people who are registered in the system who belong to a particular economic bracket in the country. So the effort also involves, as part of the effort to expand coverage, well, an effort is being made to have various subsidies monitored such that a person can receive those different subsidies or forms of support without having to lose one as a condition of getting another. And that's what's happening right now. If you access one of them, then you lose the possibility of access in respect to some of the others. So there needs to be an integral system that monitors all these needs and at the same time expands coverage gradually, for which, of course, there needs to be a country budget that makes it possible to gradually increase that coverage. That's the idea. Thank you, Claudia. Christian from Colombia is asking to know what is being done to take on the deteriorating health situation of informal caregivers. And this is related to another question we got from Chile, which says, in your opinion, how should healthcare systems be responding to this reality? Is there some experience in which the situation of the caregiving person has been included in a health risk assessment, for example? Now, what's being done in terms of care, based on what I've been able to take stock of in Latin America, it's a very mixed bag. There are some countries in which there is no policy for this, and there are others which, as you suggest, as I've shown, such policy is being developed. Some are further along than others. Now, in terms of health, what I have seen is that one does not yet find assessments, or there may be such an assessment, but in the healthcare system, you're evaluated or categorized as a caregiver. Well, there's no preferential access after that. It's like they evaluated you, they know you're a caregiver or an informal caregiver, and that is in the record. But the attention is more focused on the person who is dependent. So an effort is underway, and there are now benefits to consider both the person being cared for and the caregiver in the system. And there have been isolated efforts in different local communities by the local governments, hospitals, and primary healthcare centers. But in my opinion, if they're not part of an integral formal policy, these will continue to be isolated efforts. And that's why it's so important that the countries have these integrated systems so as to expedite such an offer. We're now getting to the end of the Q&A, but I must ask you one more question. I apologize to all of those who have posted questions that we've not got to here. Laura from Colombia is asking, in your opinion, please be quick, Claudia, how long does it take to get to a formal caregiving system? And in terms of training, how long should it be? How long is the training of an informal caregiver? And how long should training be for a professional, formal caregiver? Well, I'll give you my impression in this regard. The last thing, which is how long should it last? Well, I think it's going to depend a great deal on whether the caregiver has some prior training or no. Informal caregivers generally, well, the training systems usually consider 8 to 10 sessions. I'm talking about what is at the state level, with covering different topics. When it comes down to it, it should be 2 to 3 months of training in order to acquire the basic skills to be able to provide care. And in terms of a formal caregiver, I imagine it's more or less the same time. Nonetheless, one must also cover other aspects such as organizational ones and mental health within an organization if you're going to work there and so on. But I think that the trainings are basically that 2 to 3 months. And the first part of the question, I'm sorry, it slipped past. Well, I think that's fine because we need to close out, and it was a very tough question. So thanks for trying to answer it. And we can have another seminar where we also talk about how much time a country needs in order to get to a formal caregiving system. But thank you so much for this presentation. I really enjoyed the Q&A because you were very quick in answering, and we were able to get more questions than in other seminars. So thank you.
También gracias a todos los participantes.
And also, I thank all the participants in the seminar. In just a few days, you'll receive an email with a link where you'll be able to access the recording of this seminar and the presentation, and it'll be in both languages, in Spanish and English. You'll also be able to download these materials from our website of the Panorama of Aging and Long-Term Care of the IDB. I now conclude this seminar with a word of gratitude to those who've made this kind of seminar possible, particularly the rest of the Panorama team of the IDB, Pablo Barraran, Fiora Labenadetti, Deborah Oliveira, and Natalia Aranco. And I would also like to thank the technical and communications team, Diego Vapores, Soledad Planes, Narumi Yakiti, Sandra Iriarty, Lisi Manrique, Angelica Mendez Acosta, Sol Sasaturil, and Hugo Ramayo, and likewise the interpreters, Nancy and Charlie. Thank you so much for being here today, and we hope to see you soon.